have discussed the altered urinary pattern. Now, the altered urinary pattern, we have three. We have the urinary. We have three altered urinary pattern. What are those?
Retention.
The urinary retention, urinary incontinence, and your neurogenic bladder. Now, the term itself explains what's going on. So when you say urinary retention, what's the problem with that patient? Urinary retention is a patient who suffers from bladder relaxation or bladder contraction. It's the bladder contraction. Bladder contraction or bladder relaxation? Retention. It's the relaxation. So is there spasms? Will there be spasms or will there be flaccidity of the bladder? It's flaccidity. Now again, we have discussed before that the bladder tends to contract once it's containing how many ml of urine?
700.
Okay, again, the total capacity of our bladder is 750, but it would start to have this, it would be stretched if it's containing 200 to 250 ml of urine. So again, once the bladder has been stretched to 200 to 250, what does it do is that it sends the signal to the brain, and the brain tells you to have the urge to urinate. So if a patient has urinary retention, what happens to them is that the bladder is not contracting, the bladder is always relaxing, bladder is flaccid. So if bladder is flaccid, what will happen? The patient will not be able to empty their bladder. Now, what can be a complication of a patient who suffers from urinary retention?
Infection.
It's an infection. What type of infection? Urinary tract infection. Urinary tract infection, let's be more specific. Which urinary tract will be infected? Which urinary tract will be infected? Bladder. So if bladder is infected, how do you term that? Cystitis. So if bladder becomes infected, it's what you call cystitis. So you will usually have urinary tract infection resulting to cystitis. Now, if you say urinary incontinence, what does that mean? No more. It's 1:20. We started too late already. So there will be urinary if it's incontinence, contraction, relaxation. If it's urinary incontinence, is the bladder flaccid or spastic? Spastic. So if it's spastic, it's performing spasm. So if uncontrollably you have bladder spasm, you will uncontrollably leak your urine. So if it's urinary incontinence, there will be involuntary leakage of the urine because of an involuntary spasm or bladder spasm. So if a patient has urinary incontinence, what's your concern? It might be an impaired skin integrity. So that's your urinary incontinence. Now what about your patient who has neurogenic bladder? Neurogenic bladder is the combination of both, wherein your patient might have incontinence, flaccidity, or spastic bladder. Now, we also discussed the different types of infection in the urinary system. Now, of course, if it's urinary tract infection, can you expect fever from the patient? Yes. Pain from the patient? Yes. Can you expect the patient to have bleeding in their urine? Yes. Where is the pain coming from in a patient who has UTI? What's the reason why do they have pain? It's because of the inflammation. Fever is also because of the inflammation. Now, where is the bleeding or blood in the urine in a patient with UTI coming from?
Bladder.
It's from the bladder. How do you term that blood in the urine? What's the term for the blood in the urine? Blood in the urine, you call that your hematuria. Now, why would the patient who has urinary tract infection, when I say urinary tract infection, the infection might be coming from the kidney, down to the ureter, down to the bladder, down to the urethra. Now again, the four major organs in the urinary system was the kidney, the ureter, the bladder, the urethra. Now, why would the patient who has UTI, why would they develop hematuria? It's because once there's infection, the microorganism scars the lining of this organ, and once it's scarred, once it gets wounded, it periodically bleeds, causing this blood to be present in the urine. Would you normally see an RBC in the urine? No. What about if a woman is menstruating? Is it normal for them to have blood in the urine? No as well, because the urine doesn't mix, should not mix with the menstruation. The urine comes out from the urethra, menstruation comes out from the vaginal opening. So the urine should never be containing RBC. Now, if it's UTI, let's be more descriptive. If it's UTI of the bladder, what's the term for that? Cystitis. If it's the urethra being infected, you call that your urethritis. If it's the kidney being infected, you call that? If the kidney. Pyelonephritis. What's the most common type of infection, of urinary tract infection that is usually seen in women causing chronic pelvic pain? Interstitial cystitis, where it affects the interstitial spaces of your bladder. Now, let's be more descriptive. Though all UTI will have pain, but how would you know if the pain is coming from the lower and upper? If it's an upper UTI, where would you expect the pain? Upper UTI, what does it affect? Kidney. So if it's the kidney, it's pyelonephritis. What kind of pain do they usually have? Low back pain. Now, what's the other term for that low back pain? Costovertebral angle pain, or your CVA pain. Costovertebral angle pain, or your CVA pain. Now, what's the other term for that? Retroperitoneal pain. Now, why? Where do you locate your kidneys? Okay, retroperitoneal. Well, do you locate that retroperitoneal? It's right below your rib cage. So, what else? If your patient is suffering from cystitis, where is the pain?
Urethra.
If it's the bladder, if it's cystitis, it's lower abdomen, or the suprapubic region, or the hypogastric region. Now, what else? What if it's the patient is suffering from urethritis? Where will be the pain? Just imagine, what's the purpose of your urethra?
The urethral pain. It's right. It's pain.
It's right. It's where your patient. It's the last point wherein the urine is excreted. So if there's inflammation in there, if the urethra is wounded, what would you expect from the patient? It's painful urination. What do you call that? Dysuria. Now, what about if it's for the male, wherein the prostate gland is having inflammation? The patient will suffer from painful. Okay, it's a painful prostate. You call that your prostadonia. So those are the infections that we have discussed. We've also started with the obstructive disorder. The first two obstructive disorder that we have discussed will be your obstructive uropathy. Urinary obstruction, you will usually have obstructive uropathy. Now, once your patient suffers from obstructive uropathy, what's the risk of your patient? Once your patient suffers from obstructive uropathy, we have discussed urinary obstruction. Once your patient suffers from obstructive uropathy, what is the risk of your patient? The fluid goes back into the kidney. If the bladder cannot eliminate the urine will find its other compartment where it can stay, and it can stay in the kidney, causing a lower pressure, resulting to a decreased blood flow to the urine. Can it cause death of the nephron? Yes. Again, if there's urinary obstruction, what happens to the urine? It goes back to the kidney. If there's urine in the kidney, then can the blood go into the kidney? No, because the kidney is preventing a pressure coming from the outside circulation. So this can cause your patient to have a damaged nephron. If obstructive uropathy damages the nephron, you will now term that as obstructive nephropathy. So again, if your urinary obstruction, if your obstructive uropathy damages the nephron, and the reason behind is because the urine is not flowing very well, you should now term it as obstructive nephropathy. So again, we have discussed that urinary obstruction is any obstruction through the urine pathways. Again, from the kidney it will be produced, it will flow to the ureter, it will be stored in the bladder, eliminated through the urethra. So if any of those area becomes obstructed, the urine cannot flow, the urine goes back to the kidney. If there's urine in the kidney, can the blood flow to the kidney? No. If the blood cannot flow to the kidney, can the kidney be oxygenated? No. If it's not oxygenated, can it damage the working force of your kidney? Yes. What's the working force of your kidney?
I'm sorry.
Yes.
Sorry. Okay, so if the bladder is full, the blood can't flow to the kidney?
Yes.
Okay, thank you.
Kidney, ureter, bladder, urethra. Say there's an obstruction here on the bladder. Urine fills your bladder. If the bladder cannot contain it anymore, the urine goes up to the ureter. Once there is a lot of urine here, it will go back to your kidney. Now remember, kidney is being supplied with blood by the heart. Now what's the two reasons why the heart would supply blood to the kidney? First is the blood needs to be filter. The second is the kidney needs the oxygen. So in short, the heart, when it pumps blood to the kidney, it has to pump with force so that it will be able to penetrate the kidney. But if there's urinary obstruction, this will create an increased pressure in the kidney. So if there's an increased pressure in the kidney, would the heart be able to pump blood to the kidney? No. So if it's not able to pump blood into the kidney, would the kidney be able to filter the blood? No. Will the kidney be able to get oxygen? No. So if the kidney doesn't get oxygen, it will damage its working force. Now, what's the functional unit of your kidney? Nephron. So if the nephrons doesn't get oxygen, your nephron will get damaged. You call that your nephropathy. So the complication that can happen from urinary obstruction or urinary or your obstructive uropathy is obstructive nephropathy. So that's your urinary obstruction. Now we also discuss one type of urinary obstruction wherein the fluid gets trapped on the calyces of the urinary system. What's a calyx or what's a calyx? What is a calyx? What are calyces or what's a calyx?
It's the cups that the nephrons put the urine into after they made it.
Okay, here. This is your heart, your kidney, ureter, bladder. This is your kidney. Right on the end of the kidney or right at the end of the nephron, you have the end point where it is the one that catches the urine before it goes to the ureter. So right the end of a nephron is actually a collecting duct called calyx or calyces, wherein it's the one that collects the urine to drain it to the ureter. Now, if this calyx traps the fluid, if this calyx tends to trap the urine, this will cause this calyx to become overly dilated. Now, overdilation of the calyx results to fluid going back again to the urine, to the kidney, and that is what you call your hydronephrosis. Now, this hydronephrosis would usually cause dull flank pain if it's slow onset or a chronic hydronephrosis, and it will cause a sharp stabbing pain if it's an acute hydronephrosis. Again, hydronephrosis, from the word itself, it's water in the nephron. Now, why did the water accumulate in the nephron? It's because of the renal pelvis, specifically the calyces, becoming overly dilated. Now,
what was the calyx again? I couldn't get that part.
The calyx is the end connection of your, this is your nephron, renal tubules, distal convoluted tubules. Right at the end, you have a calyx. So this is your glomerulus, proximal convoluted tubules. Right on the end will be your calyx. So the calyx is the one that will collect the urine before it drains it to the ureter. So if the calyx becomes obstructed, it first becomes dilated. The fluid that it contains, it goes back to the kidney, and that's what causes the kidney to become fluid-filled. Fluid-filled kidney is hydronephrosis. Fluid-filled nephron is hydronephrosis.
Calyx collect urine before going to
ureter. So again, calyx is the one that will collect the urine before it goes to the ureter. Before the nephron drains the urine to the ureter, it will first pass the calyx, and once the calyx becomes dilated, it will not be able to empty the urine, and that could cause the urine to go back to the kidney. Now, if hydronephrosis is chronic, it will cause a dull aching pain or dull flank pain. When I say flank, where is that? Dull flank pain, dull aching pain. Where is that? That's your costovertebral or the costovertebral or your low back pain. If it's a acute hydronephrosis, this will cause a severe stabbing flank pain. It will cause a severe stabbing, sharp, acute pain on your patient. Now, of course, if there's overdilation of your calyces, it will always affect your brain, and the brain will tell you something is wrong, resulting you to have nausea and vomiting. But of course, if there is a severe dilation, the brain will tell you to pee, so you will have the urinary urgency. You have the need to go to the bathroom, but once you go to the bathroom, the time it takes before you start the urination will be prolonged compared to the time it takes you felt the need to urinate. What do you call that? The time it takes before you actually start peeing compared to the time it takes wherein you feel that you have the urge to urinate. What do you call that? hesitancy. So a patient who has hydronephrosis would have an increased urge to urinate, which is your frequency, and they will also have the prolonged time between the start and the feeling of urination, and that's your urinary hesitancy. So that's your hydronephrosis. Now, the next type of obstructive disorder will be your urolithiasis. Now, from the word itself, lithiasis means stone. So this is the urinary stone. So urolithiasis is your urinary stone. Now, or this is the formation of a urinary calculi. Now, why do we develop stone in the urine? Most of the time, it's because it's coming from minerals that we take. What's the most common type of minerals that causes calcium? That causes your stone to your urine to have stones? It's your calcium. What else?
Uric acid.
Uric acid. What else? Your purine-rich food can cause your patient also to have urinary stone. Now, therefore, if your patient is having the risk of urinary formation or stone formation, you have to prevent this urinary formation by what? What's the most practical way of preventing urinary stone? Hydration. So if you increase the oral fluid intake, you prevent consolidation, solidification, or you will prevent the calcium minerals to precipitate and form a stone. And that's the reason why hydrating, increased fluid in the blood will prevent your calcium to become solid or to form a stone. Now, there are different types of urolithiasis. If the stone is found in the kidney, you call that your nephrolithiasis. If the stone is found on the ureter, it's of course ureterolithiasis. If the stone is found on the bladder, cystolithiasis. So again, there are different ways of terming stone in the urinary system. If it's found on the kidney, it's nephrolithiasis. If it's found on the ureter, then it's ureterolithiasis. If it's found on the bladder, it's cystolithiasis. Now, a person can have urolithiasis. Urolithiasis is the general term of having a urinary stone in any part of the urinary system. What are the four major parts of the urinary system? Kidney, ureter, bladder, urethra. Now, if the stone is on the kidney, you call that nephrolithiasis. If the stone is on the ureter, ureterolithiasis. If it's on the bladder, that's cystolithiasis. Now, a person can be asymptomatic. Even a person who has urolithiasis can be asymptomatic. Now, it depends on what? A person who has urolithiasis can be sometimes asymptomatic. You might have urolithiasis, but you're not aware that you're having those. Now, what is the reason why you can be asymptomatic? It's because of the why can a person won't show any signs and symptoms that they are not having stone formation? It's because of the size of the stone. If the size of the stone is less than 4 millimeters, it doesn't usually cause your patient to have symptoms. If the size of the stone is less than 4 millimeters, it doesn't usually cause your patient to have signs and symptoms. If the stone gets dissolved with the fluid in the urine, it would usually normally cause your patient not to develop any symptoms. Now, if the stone obstruct one area of the kidney, if the stone obstruct one area in the urinary system, then that's the time your patient will have the general symptoms of having severe flank pain. The patient will have a severe pelvic or flank pain. The patient will not be able to perform activities of daily living once they have stone formation. Now, this severe flank pain would usually be relieved once there is passage of the stone. This pain would usually be relieved once the stone that has been occluded was able to pass through that urinary system. So in this patient who has urolithiasis, what do you think is the most common thing that most common consideration that you have to tell them to determine if they are really having stone? These are the patients who would usually complain of pelvic pain, flank pain. And then once they urinate, they will say, oh, I don't have the pain anymore. Now, therefore, to confirm if they have stone or they don't have stone in the urine, what's a procedure that they can do even at home to determine if they are having stone formation in the urinary system? What do you tell them to do whenever they urinate? What do you check their urine? How will they be able to check their urine? When they urinate, they have to strain the urine. Strain the urine, sieve the urine. These are the terms that they are using. Strain or sieving the urine is a way to determine if you are having urinary stone formation. Sieving or straining the urine is a very good way of determining if your patient is having urinary stone formation. Now, of course, if there is pain, it will cause nausea and vomiting. Now, where will the hematuria be coming from? As the stone passes through your bladder, through your ureter, it starts to scratch the lining of your bladder. Therefore, having blood in the urine does not just tell you that there's infection. It might also be an indication of it might be because of the formation of the stone. So, blood in the urine doesn't just indicate infection in the urine. It can also cause stone. It can also be because of a stone formation in the urinary system. Now, what are the causes of your urolithiasis? What are the causes of your urolithiasis? First is, of course, because of dehydration. Now, why does dehydration causes your patient to have stone formation? It's because dehydration causes crystallization of minerals. This causes crystallization of minerals. Now, what are those minerals that tends to crystallize? First and foremost, calcium. What else? Purine-rich food. Purine-rich food is the one that causes you to develop uric acid or uric acid stone in the urine. What else? Magnesium also tends to crystallize in the urine. Now, calcium, purine foods that can cause uric acid, and magnesium tends to crystallize whenever there is dehydration. Now, of course, fluid, once it's decreased, what happens to the concentration of your urine? Okay, once you have dehydration, what happens to the circulating fluid volume? Decrease. Once you have dehydration, the circulating fluid volume becomes decreased. So what happens to the concentration of your blood?
Of the blood or
blood?
urine?
Blood. Increase. So if there's a blood concentration becomes increased, this causes your kidney to promote reabsorption. When I say reabsorption, what does it do? It causes fluid to go back to the circulation because you want to further dilute the blood. So the more you become dehydrated, the more your blood becomes concentrated, the more the urine becomes concentrated, the more there is crystallization of the minerals. So that's one reason why your patient would have stone formation. What else? Any form of urine obstruction. Any form of urine obstruction. Now, why would the urine obstruction? Why, if the urine is not flowing very well, why can it cause your patient to suffer from urine stone formation? It's because of stasis. And if there's stasis, there will be accumulation of minerals. So once the minerals accumulate, this can cause your patient to, of course, have stone formations. Again, another is because of a urine obstruction. Once there is urine obstruction, of course, there will be stasis. And this stasis causes accumulation of the minerals, causing your patient to suffer from stone formation. Now, what else? Another is because of a nerve damage. Another is because of a nerve damage. Now, again, what causes us to urinate? It's because of what causes us the feeling to urinate? It's because of the signal being sent by the bladder. Now, if there is a decreased signal sent by the bladder, if there is no signal sent to the bladder, or if there is a signal sent by the bladder but the neurons is not reacting to it, would that cause you to have urinary stasis? Yes. Now, if there's a decrease or nerve damage, this will cause a decreased peristalsis on your urinary system. This will cause a decreased peristaltic activity on the urinary system, or specifically to the tubules of your nephron. Now, again, how how does the urine flow from the artery going to the glomerulus? What do you need? A pressure. What is that pressure?
Peristalsis.
What is the pressure that you need so that the blood from the heart will be filtered by the glomerulus? Remember, there should be a high pressure coming from the heart going to the arterioles so that it will go to the nephron. What type of pressure is that? Hydrostatic pressure. So that the blood will go into the glomerulus, you need hydrostatic pressure so that it will push the blood to the nephron, so it will start to be filtered by your glomerulus. Now, once the blood has been filtered, the solutes or the dirty blood now goes to the renal tubules. Now, how does this fluid flow on the renal tubules? It's because of the peristaltic activity of your renal tubules. So once there is nerve damage in your nephron, so there will be no peristaltic activity, there will be stasis again of this urine. Now what else? The last will be, it's because of the bladder irritation. The last reason why a patient might be developing stone is because of a bladder irritation. Now bladder irritation can be due to chronic irritation. Now chronic irritation from foreign objects. Now what can be a foreign object that can chronically irritate a patient's bladder? What type of foreign object, what is the most common foreign object that can chronically irritate the bladder?
Bacteria.
It's your catheter, right? So if a patient needs continuous catheterization, will that cause chronic irritation of the bladder? Yes, that chronic irritation causes your bladder to become flaccid, and once it's flaccid, it decreases its motility. It will also cause your urine to be stasis. So again, once there's bladder irritation such as your urinary catheter insertion, this will cause your bladder to become less reactive next time. Less reactive bladder will cause urine retention, urine incontinence. Retention. So if there's retention, there's stasis. Stasis results to stone formation. Now, once your patient, yes,
When you say status,
poor flow of the urine, decreased flow of the urine. Stasis is a stagnant flow of the urine. It's not moving. That's stasis. Stasis of the urine is a poor flow of the urine, decreased flow of the urine. It's a stagnant flow of the urine. It's not flowing, in short. There's a slow flow of the urine. So all of this can cause stone formation. Now, once your patient has urolithiasis, what can be done to your patient? Now, let's see what can be done to your patient. First, antibiotic, fluids, ambulate, strain, and surgical procedure. Among these five, which is the first and foremost nursing intervention that you should advise your patient? If you will be asked, the patient has urolithiasis, what is a very good nursing intervention? 1, 2, 3, 4, 5.
2.
What is a very good nursing intervention? 1, 2, 3, 4, 5. A patient noted to have urolithiasis, having difficulty in urinating, having problems in performing activities of daily living because of a big stone on the bladder or because of cystolithiasis. What is a very good nursing intervention? Is it 1, 2, 3, 4, 5? It would be 2. Nursing intervention means you have to do something to decrease the symptom. You have to perform something to decrease the symptom. Antibiotics take it out. First and foremost, it doesn't cure the... Why do we need to give antibiotic to a patient who has urolithiasis?
Prevention of infection.
To prevent infection, which means, do you have infection in urolithiasis? No. But is the patient prone to infection? Yes. Can you just imagine, this is your urethra, stone keeps on scarring, keep on lacerating your urethra, then that will be making you prone to infection. So give an antibiotic. If the antibiotic is given to prevent an infection, what do you call that? Prophylactic treatment. So again, what can be a prophylactic treatment to a patient who has urolithiasis? Your answer can be antibiotic. Now, encourage fluid intake. Of course, the most common reason because their stone formation is because of dehydration. So this will increase the hydration status of your patient. Now, what about ambulation? Why does ambulation prevent urolithiasis?
person is moving.
Because the more you move, the more the urine moves. If you move, it will stimulate peristaltic activity of the renal tubule. If you move, if you stand, if you jump, if you walk, by gravity, it helps in the good flow of your urine. So again, movement can cause good peristaltic activity. Movement can cause a good vascular tone. Now again, when I say vascular tone, why do we always need to have a good tone of the blood vessel? It's because if you have a good tone of blood vessel, the blood vessels always perform a peristaltic movement. It's having spasm. It's having contraction. Now again, once our heart contracts, all the blood vessels that supplies all the arteries of our body will start to have it performing its spastic activity to always move the blood. Now, do we need its spastic activity from the blood vessel? Yes, specifically if it's an artery supplying the brain. By gravity, all the blood vessels that supply the lower extremity doesn't need to exert effort in supplying your legs, because by gravity, if they stand, automatically the blood will go to the leg. But what about the brain? There should be a good vascular tone that will develop that will help this blood vessel to deliver the blood from the heart going to the brain. So ambulation improves peristaltic activity, not just of the nephron, but also because of your blood vessel. What else? Gravity, standing, walking, jogging, running helps in the good drainage of the urine. Now what else? Straining the urine will actually identify formation of the stone. It will help in identifying if there is stone formation. Now, when I say surgical procedure, cystoscopy is what?
Looking at it.
Visualization of the bladder. Ureterolithotomy is?
When you say strain urine, what does it mean?
Removing it from the
When I say strain, it's like when you cook spaghetti, if you want to separate the water and the noodles, then you have to strain the noodles. That's how you separate the noodles from the water. That's straining.
Yeah. No, I know, but in here, in urine, how do you separate it?
You have to strain. You have to use a strainer.
Oh.
Literally, you have to use a strainer to identify formation of a stone. Literally, you have to use a strainer.
Okay,
Now, surgical procedure involves cystoscopy. Now, actually, this should be cystostomy. When you say cystoscopy, what do you mean by that? It's visualization of the bladder. What about if it's cystostomy?
There's a hole.
You have to put a hole in your bladder. Now, why do you need to put a hole in the bladder? To drain the stone. If you want to drain the stone from the ureter, it has to be on the ureter. If you want to drain the stone from the nephron, it has to be nephrolithotomy or pyelolithotomy. Now, what about lithotripsy?
Oh, dissolve the stone.
This is your ESWL, or the extra corporeal shockwave lithotripsy. Again, lithotripsy or ESWL, the complete name of that is ESWL, or your extracorporeal shockwave lithotripsy, is a a non-invasive procedure wherein you will be dissolving the stone with the use of shock waves or with the use of vibration. Now, before, how they do it is that they will ask the patient to lay down on it seems like it's like a bathtub filled with water, and they will deliver shock waves on the water that will cause vibration, strong vibration that will intend to dissolve the stone that is present on the urinary system. So again, before, how they do this lithotripsy is that they will ask the patient to lay down on a bathtub filled with water. They will deliver shock waves on the water, and the waves can cause strong strong vibration and sound on the stone present on the urinary system that will cause it to dissolve or crash. Just imagine if a person sings and the glass breaks. That's the principle that they are using on the lithotripsy. Now, nowadays, it's not that way. they will just lie on a table, and they will a light will be passed through the urinary tract, and the light contains shock waves that will deliver the vibration that will cause the stones to become dissolved. That's your lithotripsy, a non-invasive surgical procedure which intends to crush or dissolve the stone. So if you will be asked, what is a very good nursing management to a patient who has urolithiasis, should you answer 1, 2, 3, 4, 5? You answer number 2. If the question is, what is a very good nursing procedure that can help identify presence of a stone? Of course, you answer number 4. Now, what is an invasive procedure that will help in eliminating the stone in the urine? You answer. What's an invasive procedure that can be done to eliminate stone in the urine? You answer. 1, 2, 3, 4, 5, 6.
Stomach.
What is an invasive procedure that can be done to eliminate big stones in the urine? You answer 1, 2, 3, 4, 5, 6. 5. Invasive, 5. What's a non-invasive way of dissolving the stone? 6. Now, what's the best way to prevent complication of urolithiasis? What's a management that can prevent complication of urolithiasis? It's 1. It's because one of the most common complication of urolithiasis is, of course, infection. Aside from infection, what can be a complication out of urolithiasis?
Kidney failure. Damage to the nephrons.
There. What can be a very good, based on the clinical manifestation, what can be another complication that can arise having urolithiasis? Based on the clinical manifestation, what can be one more complication that can happen to your patient who suffers from urolithiasis?
Sepsis.
What did you say? I'm hearing.
Dehydration.
Dehydration can be happening to your patient because of the nausea and vomiting. What else?
Anemia.
Anemia coming from hematuria. So you also have to consider giving iron-rich food to a patient, specifically if the patient is showing bloody urine. So again, if the question is check all that applies in a patient who has urolithiasis manifesting flank pain, nausea, and vomiting, hematuria, should you answer giving a lot of fluids? Yes. Should you answer giving pain medication? Yes. Should you answer giving iron-rich food? Yes. If hematuria, nausea, and vomiting, and flank pain are all in the symptoms, all of these symptoms needs to be managed, including their complication. So again, in NCLEX, you don't just answer 1. You might be asked to answer all that applies. If you miss 1, you miss it could cause you to have a wrong answer on that concept. So that's your urolithiasis. Yes.
Excuse me, do we have in the book lithotripsy?
Yeah, there should be some. I think there is. There is a lithotripsy in there. So these are like surgical procedure on how you will be able to remove stones. So this involves the cystostomy or cystoscopy, ureterolithotomy. So these are the surgical procedure. Now let's go to your renal tumors. Renal tumors or tumors in the kidney are one reason why your patient would also suffer from urinary obstruction. Renal tumors or having overgrowth in the urine in the nephron can also cause your patient to suffer from urinary obstruction. Now, when you say renal carcinoma is also called your hypernephroma. This is also called as your hypernephroma. So renal tumors is also called as your hypernephroma. So what else? The most common site of tumor formation in the nephron will be on your distal convoluted tubule. So again, renal carcinoma is an overgrowth in your urinary system, and it's also known as your hypernephroma. Now, the most common area wherein they would usually occur, it would be in the proximal convoluted tubules. The most common area where it will usually occur will be on your proximal convoluted tubules. Now, What are the two major parts of the nephron? Renal corpuscles and renal tubules. Now, what is found on your renal corpuscles? These are your glomerulus. What are the three renal tubules? You have your proximal convoluted tubules, your loop of Henle, and your distal convoluted tubules. On the glomerulus, it performs the first stage of urine formation, which is your filtration. The renal tubules perform the second and the last stage of urine formation, which is the reabsorption and secretion. Proximal convoluted tubules perform the process of proximal convoluted tubules perform the process of reabsorption. Now, and proximal convoluted tubules is the most common area wherein there will be tumor formation. Now, if a patient has this, etiology is adenocarcinoma that develop unilaterally. When you say unilaterally, it affects one, if it affects both. It affects one or it affects both.
One, if it's unilateral.
If it's unilateral, it just affects one area, one region. Now, clinical manifestation will be an intermittent, painless hematuria. It will be an intermittent, painless hematuria. Now, why would there be a painless hematuria? Why would there be hematuria? Because these cancer cells can sometimes bleed if blood vessels rupture. Now, say for example, there is a cancer developing here on this side of this nephron. Remember, one nephron is surrounded by a lot of blood vessels, capillaries. Now, if it starts to grow and grow, it can put pressure in the surrounding blood vessels, causing the surrounding blood vessels to periodically rupture. If it rupture, of course, you have clotting mechanism. So what would you usually do? You have to form a clot. But did you bleed? Yes. Would you see this blood in the urine? Yes. Now, would it be painful or painless? Painless, because it will just be a periodic rupturing of the blood vessels, such as, say for example, you trip or you hit your elbow on the table. Can that cause some of the blood vessels to rupture? Yes. You will feel the pain because you have been hit, but you will never feel that the blood vessel ruptured. So this is the reason why your patient will have a painless hematuria. Now remember, in cancer, once the cancer becomes painful, are you on the early stage or on the late stage? Once the once the tumor becomes painful, are you on the early stage or on the last stage? Last stage. Pain is the late sign, is the last sign of cancer. Pain is the last sign of cancer. What causes a patient who has cancer to be in pain?
The tumor pressing against the nerve.
It's because of the tumor pressing against a nerve. It's because of the tumor putting pressure on a nerve. It's because of a big tumor compressing a lot of nerves. Now what else? If a tumor compresses a blood vessel, that causes a decreased blood supply to that organ reacts by telling the brain that there is pain. Now, late sign will be weight loss. Now, why would there be weight loss in your patient? It's because of nutrition being utilized by your cancer cells. It's because of the weight loss being utilized by your cancer cells. Now, the dull flank pain, whenever you hear dull, is it a slow progressing pain or an acute stabbing pain? If it's dull, it's a slow one. It's a slow aching pain. If it's a sharp pain, it's usually an acute one. So dull flank pain, dull aching pain is an indication of an increasing size of the tumor. This indicates an increasing size of the tumor. Now, of course, if the tumor has increased its size, this will now cause a palpable mass on the flank area. Now, and once it has increased in size, it will rupture most of the blood vessels that will cause your patient to have gross hematuria. It will cause your patient to have a ruptured blood vessels that will cause your patient to have gross hematuria. You call that your frank hematuria. hematuria. This will cause your patient to have gross hematuria. When you say gross hematuria, it's like when they pee, they are peeing blood. You call that your frank hematuria. So a patient who has renal cancer, renal tumors, would usually have this general manifestation. Now, what can cause a patient to have renal tumor? Cancer is still inexplainable up until now. It's still idiopathic up until now. Nobody knows why a patient would develop cancer, but cancer is usually blamed because of
Carcinogens.
lifestyle. Most common cause is
Smoking.
smoking. What else? Poor
Nutrition.
eating habits.
Immune
What
system
else?
down.
Alcohol. What else?
Benzenes, exposure to benzenes.
Exposure to harmful substances.
Pure immune system.
Okay, a decreased immune system. Now, let's see first. Lifestyle, smoking, poor eating habits, drinking too much alcohol, exposure to harmful substances. Why? All of this causes chronic irritation to your nephron. Chronic irritation to your nephron. Now again, basic concept. What's the functional unit of a nephron? What's the functional unit of a kidney? Nephron. What's the basic structure of your nephron? What's the basic structure of your nephron? Glomerulus is a part of your nephron. But what comprises a nephron? It's group of cells, right? It's group of cells. Now, our cells has different behaviors. Once there is a need for the cell to perform an activity, there is an increase size or increase, how should I say that? Yeah, increase size or an increased activity of the cell. Once a part of our body performs an activity, the cellular component or structure of that part of the body increase its size to increase its activity. Once we don't need to perform any activity, this cell need to die. What do you call that? The natural cellular death. You call that your apoptosis. How our cell behaves. Cell is the smallest structure of our body. Our body is made up of millions of cells. Now, these cells behaves in such a way that wherever a part of the body performs an activity and it increases in size, it multiplies to increase its activity. But if a part of the body doesn't move, or if the part of the body doesn't need to perform activity, the cell normally dies. It will just start to reproduce itself once there is a need. The natural cellular death is what you call your apoptosis. We don't want too much cell if it's not in use, or else it will just cause an increased size of the cell or increased size of the organ. Now, kidney as an organ is made up of cell. Now, the behavior of cancer cells is that these are the cells that continuously increase in size. There is a continuous increase in size. In a cancer cell, how does it behave is that it continues to increase in size even without the need. There's a continuous increase in size even without a need. What else? Cells are usually the one that doesn't perform natural death, or they are the one that doesn't perform apoptosis. In short, if you're not using it, they are not dying. So they do not perform apoptosis and they continually grow. So what's the major cause, or what's the major complaint, or what's the major issue or condition that your patient would usually have? It's because of the enlargement of the cell. There is an enlargement of one part of the kidney. It's because that's one part of the kidney has a group of cells that doesn't die and continuously grow. Now, the chronic irritation of the nephron is the reason why a person develops cancer cells. Now, Once a cell die, it will produce another one. Once a cell die, it will produce another one. Now again, whenever a cell becomes injured, does it have to heal? Yes. What causes a cell to become injured? Once a cell becomes injured, remember, our organ is made up of cells. So once an organ becomes injured, it will perform. What does it do? Once a cell becomes injured, what does our body do? Perform
Inflammation.
healing process by performing inflammatory response. What's the goal of the inflammatory response? To perform?
Dilation.
What's the goal? To promote healing process. What does healing process involve? Creation of new cells. Now, what can cause a cell to become injured? This stuff. Smoking, poor eating habits, alcohol exposure to harmful substances can cause chronic injury to the cells of our kidney. Say, you drink a lot of alcohol, the alcohol goes into the blood, the kidney needs to filter it out. So are you continuously giving alcohol to your kidney? Yes. What else? You go to a textile company, you go out to a polluted area. Do you inhale the carbon monoxide? Yes. Does it go to the blood? Yes. Should the kidney filter it out? Yes. Are you giving carbon monoxide to your kidney? Yes. So any exposure to harmful substances can also cause exposing your kidney to these harmful substances. That can cause the cellular component of your kidney to become injured. Of course, a kidney needs to heal. As it heals, it creates a new type of cell. If you are unlucky this time, yes, you might be creating new types of cells. But what types of cells? A cancerous cell. Once it's a cancerous cell, what does it do? It continuously increasing its size without performing natural death. Now, what's wrong with this? This type of cell are usually migratory. They tend to go to the different parts of the body. That's the reason why cancer cells are usually metastatic. Why? It's migratory in nature. It usually goes to a different part of the body wherein it will start to multiply, it will start to grow, causing the cancer cells to start to metastasize. Now, cancer cells tends to metastasize in an area wherein there is an increased vascularity. Cancer cells increases its metastatic rate if it occurs in a highly vascular region of the body. Is renal or kidney a highly vascular part of the body? Yes. 20 to 30% of the cardiac output goes to the kidney. After the brain, kidney gets the blood. So in short, if kidney is highly vascular, renal cancer is highly metastatic. One cause of that, again, lifestyle. Next, chronic hypertension. Chronic hypertension can also cause your patient to have renal cancer. Why does hypertension causes a patient to have renal cancer? Let's see. In hypertension, what happens to the ventricular contraction of the heart? In hypertension, what happens to the ventricular contraction of the heart? Is it strong or light? Strong. What causes the ventricles of the heart to have a strong pump? Is it because the blood vessels is narrow or wide? Narrow. If it's narrow, do you have to strongly push the blood? Yes. A narrow blood vessels pushes the blood, causes the heart to push, to give a strong push to the blood so that it will go to the different parts of the body. In short, in a medical term, vasoconstriction can cause myocardial contractility resulting to hypertension. Now, therefore, if there is hypertension, your major problem here is vasoconstriction. Now, once there's vasoconstriction, what happens to the blood flow?
Down.
If there's vasoconstriction, what happens to the blood flow? It starts to decrease. Once blood flow starts to decrease, where should the bulk of the cardiac output go first? To the brain. So would you have lesser amount of blood going to the lower extremity? Yes. What is that important organ that should get the blood? It's the kidney. So this decreased blood flow will cause a decreased O2 perfusion to the kidney. But of course, if kidney is not well perfused, what happens to its cell? dies. It will have an injured kidney. Injured kidney, will that cause the cell again to heal? Yes. An injured kidney because of a decreased O2 perfusion, would that cause the kidney to always heal? Yes. Healing can involve creation of new cells. If you're unlucky, you might create a cancer cells. This can cause your patient to have renal cancer. So chronic hypertension can also cause your patient to suffer from renal tumors or renal cancer. And of course, cancer, last cause will be genetics. Hereditary. In short, it runs in the family. If one family suffers from cancers, then that tells you that you have inherited, you might have inherited a gene that contains cancer cells. Now, study shows that all people contains cancer cells. But in some people, the cancer cells behaves very well that it doesn't perform an activity. In some people, cancer cells are hyperactive, causing them to develop the complications of cancer. So it's in the blood, it's genetics, it's hereditary, there's familial predisposition in cancer. Now, what will be the discrete sign of cancer formation? The cancer will only have manifestation once there's an increase in size of the cancer cells. Once there is an increasing size of the cancer cells. Again, what's the initial phase? What's the first sign of renal cancer? Painless, painful?
Painless.
Painless, hematuria. So in the initial stage of renal cancer, the patient will have painless hematuria. She will be bleeding, but they will not have any pain. So would this cause this patient to go to the doctor? No. The patients will just go to the doctor once they have an alteration in the activities of daily living. Now, as the cancer cells increase in size, of course, you will have a palpable mass. Now, this palpable mass can cause your patient to have an increased abdominal size. So, what can be a sign of cancer cells? Increased abdominal size. Upon palpation, they might palpate a solid mass in the abdominal region or the retroperitoneal region. What else? There will be chronic irritation of the urinary system. There will be a chronic irritation of the urinary system. If you chronically irritate the lining of your urinary system, what will you have again? Hematuria. Chronic hematuria causes the patient to develop anemia. So a patient who suffers from cancer will develop anemia, and what's the manifestation?
Weakness.
Weakness. Why does a patient who has anemia develops weakness?
Because they don't get oxygen.
Why a patient who has anemia develop weakness? Because they don't have oxygen delivered to the different parts of the body, because the one that delivers has a decrease in volume. What delivers the oxygen to the different parts of the body? Hemoglobin. And what's happening to the hemoglobin of a patient who has hematuria? Decrease. So if you bleed, you don't have hemoglobin. If you don't have hemoglobin, the oxygen will not be carried out to the different parts of the body. So you will develop weakness. What else? What are the other signs of anemia?
They're always cold.
What are the other signs of anemia? They are usually pale, right? They're usually pale. Why? What's the other purpose of your hemoglobin? Aside from carrying the oxygen, is also the reason why the color of our blood is red. So generally, they would usually be weak. They would usually be pale. They are also cold. Why are they usually cold?
Less blood.
Less blood means less oxygen. Less oxygenation means less metabolism. So in short, if you don't metabolize, you don't produce heat. So again, why a patient who has anemia will usually be cold intolerant? It's because if you have anemia, you have less hemoglobin. If you have less hemoglobin, you have less oxygen. Oxygen is necessary for metabolism. So if you don't metabolize, you don't have heat production. So this is your hematuria. What else? As the cancer cells increase in size, this will cause compression of the nerves. So this will cause compression of the nerves, but of course, your patient will develop pain. So your patient will now start to having dull aching pain. Where is that dull aching pain happening? Flank region. So there will be a dull aching pain. Now what else? The behavior of the cancer cells is the one that utilizes the nutrition of your patient. That's the thing with the cancer cells. You eat, but what happens to the food that you eat? It goes straight to the cancer cells. Why? Cancer cells eat all your nutrition. So if the cancer cells eat all your nutrition, what happens to your patient?
We're gonna lose weight.
They will start to lose weight. They would usually say, I eat a lot, but I don't gain weight. So they would usually have an unexplainable weight loss. Now, if there is an increased utilization of nutrition by the cancer cells, this will cause your patient to have an unexplainable weight loss. So where does the nutrition go?
The cancer cells.
To the cancer cells. This will now cause your patient to have further increase the size of the cancer cells. This will further increase the size of your cancer cells. These are the general signs of renal cancer. But what would be specific in your renal system? This will be the general signs of cancer, but how will you determine if it's coming from the renal area? How would you know if the cancer is coming from the kidney? These are the general signs of cancer. All patients who has cancer would usually have this problem. But how would it be more specific if it's renal system? If it's the renal system being affected, it will cause an altered kidney function. This will cause an altered kidney function. Now, what kind of alteration in the kidney function your patient will have? Now, if the kidney has cancer formation, what happens to the blood vessels that supplies the kidney? Will it be obstructed or patent? Obstructed. You have a cancer formation on the kidney, blood vessels becomes obstructed. If the blood vessels becomes obstructed, how much blood can go to the kidney? Decrease. If there's a decreased blood flow to the kidney can perform a compensatory mechanism. What's the compensatory mechanism of the kidney whenever it has decreased blood flow? It will start to produce the other one, the erythropoietin. The kidney will start to produce erythropoietin. So again, if the kidney has an increasing size of the cancer, this causes the kidney to perform erythropoietin production. What does the erythropoietin do? It stimulates the bone marrow to produce an RBC. It will cause your patient to produce an RBC. But the thing is, the patient performs too much erythropoietin production, causing your patient to have the risk of hypertension. Why? Too much RBC causes viscosity of your blood. Too much RBC causes increased viscosity of the blood. How does the kidney have an altered function? It's because if the kidney produce too much erythropoietin, there will be too much production of the RBC. What will happen to your blood? It becomes more viscous. A more viscous blood will cause the heart to pump stronger, causing your patient to have hypertension. What's the other risk of having increased viscosity of the blood? Clot formation. So one problem of a patient who develops renal tumor will be your clot formation or clot formation. So these are the general signs and specific sign of renal cancer. How do we manage that? Of course, the management there is always take out the cancer cells before it start to migrate to the surrounding structure. So if you want to take out a part of your kidney, you call that your nephrectomy. The only management for cancer is to surgically remove the cancer cells. The way to manage your patient who has renal cancer is to surgically remove the part of the organ that has cancer cells. So if it's renal cancer, you call that your nephrectomy. Can you remove one kidney?
Yes.
Yes. Can you remove both kidneys? Can you remove one kidney and the patient can resume to its normal activities of daily living? Yes. Can you remove two kidneys and the patient can resume to activities of daily living? No. The patient can have their both kidney removed, but they have to depend on Dialysis lifetime. So radical nephrectomy. Now, usually in cancer, after removing the part of the body or after removing the organ that has the cancer, series of treatment would also be done. Now, what's the next treatment that can be done? Radiation therapy. Now, in radiation therapy, it explains itself. It uses radiation to kill cells. What does it target? Of course, the cancer cells. So the doctor will have to perform radiation therapy after nephrectomy to ensure that all cancer cells should die after the removal. So again, after removing a kidney, the patient might still have cancer cells that has attached to other structure. So to ensure killing of all of those cancer cells, they have to perform radiation therapy. In radiation therapy, they will use radiation to kill all the cells. Now, what about chemotherapy? Chemotherapy is the introduction of a medication to cause killing of the cells. Of course, it targets the cancer cells. Now, when I say it kills the cells, radiation therapy and chemotherapy, it kills the cells, but this is non-selective. The problem with radiation and chemotherapy, the good thing about radiation therapy and chemotherapy is that, yes, it kills the cancer cells. The bad thing is, it doesn't just kill the bad cells, it also kills the good cells. Now, what are the good cells that it usually kills? The radiation therapy, chemotherapy, what are the good cells that it usually kills? It kills the white blood cells, it kills the red blood cells, it kills the platelets. So if the chemotherapy, radiation therapy kills all of this, what happens to your patient? Decreased WBC means patient suffers from?
Infection.
What's the term?
Leukopenia.
Leukopenia. What about RBC decreasing?
Anemia.
Platelet decreasing is?
Bleeding.
Thrombocytopenia. Let's see the risk. Leukopenia, what's the risk?
Infection.
Patient is at risk of infection. So having chemotherapy, is the patient immunocompromised? Yes. What about anemia? Decrease O2 perfusion. Will they be pale? Yes. Will they be cold? Yes. Will they be weak? Yes. What about thrombocytopenia? Risk of bleeding. So they will be at risk of bleeding. Are they at risk of shock? Yes. Are they at risk of decreased circulating fluid volume? Yes. How would you know that the patient is having thrombocytopenia? What's the manifestation? If in anemia, you'll see weakness. In thrombocytopenia, what would you see? Petechia, bruises in your patient. So how would you know that your patient is having leukopenia? Patient is having fever. How would you know that the patient is having anemia? Patient is weak, pale. How would you know if the patient is having thrombocytopenia? Bruises and petechiae. If the patient has leukopenia, anemia, thrombocytopenia, general term for these three will be pancytopenia. So what kind of risk is the patient at risk of after radiation therapy, chemotherapy? It's pancytopenia. Let's try to manage. Platelet. If the patient is having thrombocytopenia, what's your nursing consideration? Use of soft bristle toothbrush. Eat a lot of food rich in vitamin K. What about anemia? Eat food rich in iron. What about leukopenia? Eat food rich in
Cooked food.
what will increase your resistance to infection? Vitamin C. What else? If a patient has leukopenia, do you have to isolate the patient?
Yes.
Yes. What kind of isolation? Reverse isolation, strict isolation. Strict isolation, reverse isolation. Reverse isolation, strict isolation. Again, if a patient has leukopenia, is the patient prone to infection? Yes. So if the patient is prone to infection, do you have to isolate? Yes. What type of isolation? Strict isolation? Reverse isolation?
Strict, they're not going to break. Reverse.
Huh?
Strict is if there's a...
3. When we resume from the break. When we resume from the break.
Can you do that? Can you decrease so I can move my car?
Say that again.
Can you give us a break? 10 minutes to 3 so I could move my car.
Okay, so again, if the patient is at risk of infection, do you have to isolate? Yes. What kind of isolation? Strict or reverse?
Reverse.
Let's describe what is strict isolation. Who is infectious? Patient or nurse?
Patient.
Patient. Patient or nurse? If it's strict isolation, who are you protecting? The nurse or the patient? If it's strict isolation, who are you protecting? The nurse or the patient? The nurse. If it's reverse isolation, who are you protecting?
Patient.
The patient. So in a patient who has leukopenia, strict or reverse?
Reverse.
Reverse. Because do you need to protect the patient? Yes, because patient is prone to
Infection.
infection. So you have to put the patient on a reverse isolation. On reverse isolation, do you have to ask the patient to wear mask?
No.
On reverse isolation, do you have to ask the patient to wear mask? Yes. Where? When? Again, in a patient who is on a reverse isolation, when the nurse enters the room, does the patient needs to wear mask or the nurse needs to wear mask?
Nurse.
To make it easier.
Inside the patient's room, who wears mask? Nurse or patient? Who is prone to infection?
Nurse.
Patient.
Oh, we're confusing it with the reverse air, reverse pressure.
Oh,
That's when you protect the outside.
okay. Now again, it's a negative pressure. Maybe that's what you're thinking. Now, if it's a negative pressure, you're preventing the air coming inside. Now, this is different. If it's strict and reverse, if it's strict isolation, who is infectious?
The patient.
Patient. Who do you want to protect?
The patient.
Nurse.
The nurse. Again, in strict isolation, who is infectious? The patient. Who do you want to protect? The nurse. In reverse isolation, who is at risk of infection?
Patient.
Patient. So who do you want to protect? Patient. So a patient who has leukopenia, leukopenic patient, should you put them on a reverse or a strict isolation? Reverse isolation. In reverse isolation, who are you protecting?
Patient.
Patient. Because who is prone to infection?
Patient.
Patient. So inside the patient's room, who wears mask?
The nurse, because otherwise the
Who wears the mask who wears the mask inside the patient's room? Who wears mask? Nurse or patient?
Patient.
Patient must wear it.
Oh, let's do it the other way
Patient
around.
must wear it. I've never seen a patient have to wear one, but I
The
guess it's
patient, usually when they go out, they wear mask, but inside, I think the nurse make it more convenient for them, so the nurse wear.
It's like this. Inside your house, who should eat the food in the refrigerator? Your neighbor or your family?
Yes. My house is
My neighbor.
Huh? Your neighbor or your family? It has to be your family. In short, inside the patient's room, who should be more comfortable? Is it the nurse or the patient?
the patient.
So what will make the patient more comfortable? Is it wearing the mask, not wearing the mask? Not wearing the mask. Since it's the patient's room, it's the patient's territory, so who should be comfortable? It has to be the patient. So who should wear the mask?
Nurse.
Nurse. After all, who's paying the bill?
Patient.
Patient. Who occupies the room? Patient. Who pays your salary? Patient. Out of the patient's bill. In short, inside the patient room, the patient doesn't need to wear the mask. But if this patient goes out, she doesn't pay everybody in the hospital. So what do they need to do? Wear the mask. Let's do the opposite thing. That's reverse isolation. What about in strict isolation? In strict isolation, who is having the infection? Patient. Who are you protecting?
Nurse.
The nurse. So inside the patient's room, who wears mask?
Nurse.
The nurse is still.
Nurses.
It's still the nurse. Why? It's still the same. It's the patient's room, so who needs to be comfortable? Patient. Inside the patient's room, the nurse still needs to wear the mask. Now, why? Because the patient just needs to inhale and exhale on the environment anyway. That's her own virus. But once she comes out, you have to protect the entire people outside. So the patient needs to wear mask. So in both strict and reverse isolation, inside the room, the nurse wears mask. Outside the room, the patient wears mask. In a patient who has leukopenia, reverse isolation is a major issue because of the leukopenia. Now, renal cyst. Let's discuss this before you go to your break. Renal cyst, which involves your polycystic kidney disease and your singular cyst formation. Renal cyst and your polycystic kidney disease. Now, etiology-wise, renal cyst is the cyst formation in the kidney. It might be minimal or singular. So if it's just a renal cyst, it might be one area of the body or one area of the nephron, or it can be a small area of the kidney that has cyst formation. If it's a polycystic kidney disease, there is a multi-cyst formation. It is a multi-cyst formation. Now, this renal cyst is usually benign in nature. This renal cyst is usually benign in nature. In short, it forms a cyst, but it stops growing, producing another cyst. So renal cyst is usually benign. It will just grow. It will just stay there. It will not usually cause any symptoms unless it increases in size. Polycystic kidney disease is a multi-cyst formation that causes kidney structures to become compressed, altering its function. So polycystic kidney disease is a multi-cyst formation that causes pressure on the structure of the kidney, causing it to have an altered function. Now again, there's compression, there is pressure, there will be pain. Nerve compression out of that cyst formation can cause a patient to have pain. Now what else? If there is, of course, a cyst formation, this can now cause compression of the bladder. Once the bladder is compressed, this will now cause irritation of the bladder, causing the bladder to become spastic every now and then. And a spastic bladder causes the patient to have urinary incontinence or retention. Incontinence. Periodic irritation of the bladder causes your patient to have urinary incontinence. Now what else? A patient might also develop recurrent UTI. As you all know, an altered voiding pattern can always cause a patient to have urinary tract infection. An altered voiding pattern, whether it's incontinence, retention, neurogenic bladder, can always result to UTI. What else? Hematuria because of bleeding. Blood.
What is the voiding?
Pattern. Altered voiding pattern. It's an altered voiding pattern. So hematuria is because of a bleeding blood vessels. Why? It's because the cyst compresses the capillaries rupture, causing your patient to have bleeding. Now hypertension is because of the RAAS. Hypertension is because of the renin-angiotensin-aldosterone syndrome. Now, to further explain on that, your patient who suffers on PCK or polycystic kidney disease, in a patient who suffers from polycystic kidney disease, this is usually a genetic disorder. PCK or polycystic kidney disease is usually a genetic disorder, yes.
They are talking about multiply, not about singular one.
No.
Multiply.
Polycystic, yes. Multiple.
There is one cyst or many cysts. So
Yeah.
one cyst is good one, polycystic.
Renal cyst is just benign. Polycystic is the one that's usually aggressive. Okay. Polycystic kidney disease is one disorder in the kidney that is usually genetic. When you say genetic, it's traced from the family. It has a familial tendency. PCK can usually be autosomal dominant.
Is not cancer because so many?
No, it's not cancer, but it's a multi-cyst formation. Hold on. Autosomal dominant or autosomal recessive. It can be autosomal dominant or it can be autosomal recessive. This is how you differentiate everything that we have discussed. If it's hydronephrosis, what is that?
Water in the kidney.
Water in the kidney. Why did the water stay in the kidney? Because of the dilation of the calyces. If it's renal cyst, it's a single formation of cyst in the kidney. If it's a multiple cyst formation in the kidney, you call that your polycystic kidney disease. Now, if it's a multi-cyst formation, is it cancer? No, it's just a cyst. If it's cancer, you call that your
Tumor.
renal cancer or hypernephroma, which commonly occurs on the which part of the nephron? Proximal convoluted tubules. Again, let's go to the PCK. Hydronephrosis is overdilatation of the calyces. Renal cyst is a single formation of cyst in the kidney. Polycystic kidney disease is a multi-cyst formation in the kidney. Is it cancer? No, it's just a cyst that will cause an altered kidney function. If it's cancer, it's renal carcinoma or renal cancer or hypernephroma that's usually occurring on the distal convoluted proximal convoluted tubules. PCK is genetic. In short, it runs in the family. It can be autosomal dominant. It can be autosomal recessive. When I say autosomal dominant, one parent needs to have the trait before it gives the symptom to the child. One parent is enough to carry a trait so that symptom will be present in a child. So if your parent carries a trait containing PCK, you might develop the disorder. If it's autosomal recessive, two parents are required to carry a trait before the symptoms can happen to their child. So if it's autosomal dominant, one parent is enough. One parent carrying the trait is enough for a child to develop the symptoms. If it's autosomal recessive, both parents needs to carry the trait for the child to carry the disorder. Now, if it's autosomal dominant, the symptom usually occur on the middle age. The symptoms for the child to occur, it usually happens on the middle age. So this is the adult onset polycystic kidney disease. If it's two-parent, the symptoms of the child will usually be childhood onset. It's usually happening to them as a child, and this is usually happens to them. It's usually the child onset PCK. Symptoms occur when the patient is still a kid, and this is what you call your childhood onset, child onset PCK or polycystic kidney disease.
I'm sorry. Okay, so the one cyst is usually the grown-ups and the polycystic is the children?
And if it's an autosomal dominant, only one parent trait is required for it to be transferred to the kid.
Right.
Once it's transferred to the kid, they usually manifest symptoms once they go to the middle age.
Right.
That's still a lot of
And that's
cysts.
the polycystic.
It's still
Yeah.
polycystic.
But if it's an autosomal recessive, both of the parents carries the trait, the child get the disease. When will they see the symptoms? As a kid, childhood onset polycystic kidney disease. So in short, if one parent is just carrying the trait, you will have the symptom on the middle age. If two parents carries this trait, when will the patient have the symptom? It's on the childhood stage. It depends if you carry the trait. If it depends if you carry the disorder. In short, if you have three siblings, if both parents have three siblings, one might carry the trait, the other one might not. One might have the symptom, one might not have the symptom. So that's the autosomal dominant.
One parent, but if two parents trade has it, all the children will get it?
No, not really, not really. So PCK, what's the problem here is that this will cause your patient to have UTI. What else? This will cause your patient to have anemia and flank pain. But what will be more specific? These are the general signs of a patient who suffers from PCK. But what will be more specific? It's how it alters the function of the surrounding organ. The PCK, having a multi-cyst formation, causes compression on the surrounding organ. Now, what organ does it usually affect? It's the liver and the pancreas. So in PCK, the multi-cyst formation, the cyst doesn't migrate, the cyst doesn't metastasize, but the growth of the cyst causes compression on the surrounding organ. What are these organs surrounding your kidney? That is your liver and your pancreas. Now, in short, the liver will have an altered function. The pancreas will also have an altered function. Now, how would you know that the liver is having an altered function? See the general function of your liver. One of it that we have discussed would be what? What's the purpose of your liver? Bilirubin. It causes the bilirubin to be excreted. So in short, if bilirubin stays in the blood, this can cause... What's bilirubin? Bilirubin causes yellow pigmentation. Where does bilirubin come from? RBC. What's the lifespan of our RBC? 120 days. After 120 days, our RBC starts to hemolyze. Two byproduct of our RBC is the heme and globin. So normally, our blood will destroy in 120 days, then our bone marrow produces new set of RBC. So if the RBC destroys in our body, it will produce two byproduct, heme and globin. Globin is a source of iron, it will stay. Heme is the one that we don't need. Heme becomes bilirubin. And this bilirubin needs to be excreted. What excrete that? Liver. So if your patient has PCK and compresses on the liver, what happens to the blood supply going to the liver? Decrease. What happens to the function of the liver? Decrease. What happens to the ability of the liver to eliminate the bilirubin? Decrease. What happens to the bilirubin level? Increase. Where will you see that? Blood. So if there's bilirubin in the blood, this can cause your patient to have jaundice, because bilirubin causes yellowish pigmentation of your skin. Now, just for you to not to forget, say for example, somebody pinches you on your arm. Would that cause some of the blood vessel to rupture? Yeah. Yes, but of course, you will not die because of that pinch, because you have clotting factor. So if blood vessels rupture, would you clot? Yes. If you clot, is that a dead RBC? Yes. Will it start to hemolyze? Yes. It will cause heme and globin. Now, as the heme starts to hemolyze, it will cause bilirubin in that area. What happens to the color of that bruise?
Yellow.
It becomes yellowish. It's as the body is trying to get rid of itself of the bilirubin. That's why people who dies from hazing, they die not because of the bleeding. They die because of the what?
What are they dying from?
In hazing. Hazing, what do you call this? How do you say? The one who joins fraternities.
Oh,
Hazing. Yeah.
Yeah, they have to. They usually do in hazing? They have to hit them on the body just to create them their pain. If they can survive, they can be part of the group of the sorority fraternity. They die not because of pain. They die not because of the bleeding. They die because of kidney or liver failure. Why? You hit them a lot on their body, they produce a lot of blood clots. If they produce a lot of blood clots, they produce either a lot of bilirubin that causes the liver to fail because the liver fails to excrete that bilirubin, or that bilirubin stays in the blood and the kidney fails to eliminate that dead blood from the circulation. That's their usual cause of death. Now, if that liver starts to become altered, that might be because the cyst on the polycystic kidney disease is compressing the liver. So the patient becomes yellowish. What about the pancreas? What's the purpose of your pancreas? Once it becomes altered, it can cause... What's the purpose of your pancreas? Insulin formation. So this can cause an altered blood sugar level. So your patient might be hypoglycemic or hyperglycemic. So what are the things that you have to do to your patient who has PCK? Monitor the blood pressure, the blood sugar. Why do you need to monitor the blood sugar? Because PCK affects the pancreas. So one of the things that you have to do in patient who has PCK, monitor the blood sugar because PCK affects the pancreas. Now, what will be more specific in PCK? In PCK, again, how does it affect the kidney? It affects the surrounding organ, but it also affects the kidney. The kidney performs renin, angiotensin, aldosterone syndrome. The kidney performs renin, angiotensin, aldosterone syndrome. We have discussed this from first day. When I say angiotensin, what does the kidney do? The kidney converts angiotensin 1 to angiotensin 2. If the kidney converts angiotensin 1 to angiotensin 2, angiotensin 2 promotes vasoconstriction. This can cause your patient to have vasoconstriction. So, of course, whenever you hear vasoconstriction, how would you know patient is having vasoconstriction? Patient develops Hypertension. Hypertension is a major issue in a patient with PCK. They have a shooting BP. It will usually bump up to 200, 220 over 180. That's how high their blood pressure is because of vasoconstriction. In that case, which organ is suffering? In vasoconstriction, which organ is suffering? It's of course again your kidney. So this is your vasoconstriction. What about your aldosterone syndrome? What does the aldosterone syndrome do? The aldosterone causes sodium reabsorption. Now when you say sodium is reabsorbed, sodium goes back into the circulation, causing water retention. So if water and sodium becomes retained, sodium stays on the blood vessel, water goes out of the blood vessel, causing your patient to have edema. So major issue in a patient with PCK will be hypertension and edema. Why? Because the altered kidney function involves the renin-angiotensin aldosterone syndrome. That's why they benefit from the angiotensin converting enzyme, the ACE inhibitors. Angiotensin converting enzyme inhibitors prevents the angiotensin 1 from being converted to angiotensin 2. So you have to prevent sodium reabsorption and water reabsorption. Just before you go, management. There's no specific treatment to this patient. All you need to do is to just take out the cyst formation. So you have to relieve the pain, heat, unless there's ruptured blood vessels. Analgesic for pain, antibiotic for infection, antihypertensive for patient as vasoconstriction, and of course, if it's on the worst case, you have to perform renal transplant. So you just have to treat the symptoms as it occur. Analgesic for pain, warm compress if there's no obvious sign of bleeding, antibiotic to prevent infection, antihypertensive to prevent high blood pressure, dialysis, renal transplant once the kidney starts to fail. So these are your obstructive disorder. Once you come back, we'll be discussing cancer of the bladder and renal failure, BPH, and then
Excuse
we're
me,
done.
we have to remove cyst first here.
Yeah, cyst.
And then
Cyst.
everything.
So treat the symptoms as it occurs.
Thank you.